Management of space maintenance problem in children. B. Space maintenance for the second primary molar area. The loss of second primary molar usually has little effect on teeth in the anterior segment. However, the irregularity will develop in the permanent molar relationship. The end result of premature loss of the second molar is the mesial drifting of the first permanent molar with an impaction of the second premolar. 1. Space maintenance for the second primary molar area after the eruption of the first permanent molar, the same as that recommended when the first primary molar is lost, i.e. band and loop or stainless steel crown and loop. 2. Space maintenance for the second primary molar area before eruption of the first permanent molar. Mesial movement and migration of the first permanent molar will often occur prior to eruption in case of premature loss of the second primary molar. So a space maintainer that will guide the first permanent molar into its normal position is indicated, such as crown or band maintainer with distal shoe extension. The first primary molar is used as the abutment tooth. See space maintenance for the primary canine area. If loss of primary canine occurs before the eruption of the permanent lateral incisor, there is always shift of the midline and space closure. If it is lost and there has been no shift in the midline or space closure, a band or crown and loop maintainer can be used. The first primary molar is used as the abutment tooth. D. Space maintenance for the first primary incisors area. If spacing between the anterior teeth is present, there is little possibility that drifting of the adjacent teeth will occur with resultant loss of space needed for eruption of the permanent teeth. However, if the anterior primary teeth were in contact before the loss, or if there is evidence of an arch length inadequacy in the anterior region, a collapse of the arch following loss of the primary incisors is almost certain. In some patients, even the primary canines drifted mesiali out of their normal relationship. 1. Removable partial denture. It produces the desirable aesthetic appearance, re-establish function, and prevent the possibility of abnormal speech and tongue habits. Acrylic partial dentures can be constructed for very young children, if there is a degree of cooperation and interest. A removable partial denture should not be used if there is severe dental caries problem, if the child will not keep the mouth clean to reduce the possibility of dental caries activities, or if the child is uncooperative, i.e. he will not wear the partial denture or there is possibility of losing or breaking it. Advantages: 1. Maintain vertical dimension and prevents over-eruption of opposing teeth. 2. Restore masticatory function. 3. Restore aesthetic in case of anterior tooth loss. Disadvantages: 1. Often lost or broken. 2. Patient compliance and cooperation essential. 3. Requires supervision to assure compliance as well as adjust to changing conditions. 2. Modified fixed partial denture. Bands will be adapted on the last molars in the arch. A wire arch will be adapted on the bands touching the lingual surfaces of posterior teeth passively and passing over the crest of the ridge of the edentulous area, and acrylic base will be applied engulfing the wire. E-space maintenance for the permanent incisors area. The loss of anterior permanent teeth requires immediate treatment by the dentist. Within few days following the loss of a tooth as a result of trauma or extraction, the teeth adjacent to the space will begin to drift, and even within few weeks, several millimeters of the space will be lost. An impression should be taken at the time of the initial appointment or within few days. The temporary appliance can then be constructed and inserted within a matter of hours after the loss and thus prevent space closure. If any degree of space closure has occurred after the loss of an anterior tooth, the space should be regained before the construction of a space maintainer. If the child has no other irregularities in the occlusion that require the attention of an orthodontist, the general practitioner can complete the treatment. A partial denture working appliance can be used successfully in this procedure, if there is no necessity for bodily movement of teeth. Cervical clasps should be adapted to the first permanent molars to aid in retention of the appliance. Finger springs should be contoured to the teeth to be repositioned. The wire should be placed as far cervically as possible. Finger springs should be adjusted each 2 to 3 weeks. A temporary tooth replacement may be made to improve the child's appearance. After the space has been regained, a new partial denture can be constructed to serve until the time a fixed replacement can be considered. The loss of an anterior tooth occasionally occurs before the eruption of an adjacent tooth. For example, if a maxillary permanent central incisor is lost prior to the eruption of the lateral incisors, the lateral will drift mesiali during its eruption. The addition of an acrylic extension into the alveolus will normally be successful in guiding the unerupted tooth into position. F. Space maintenance for the area of multiple loss of the teeth. 1. Acrylic partial denture, indicated when there has been bilateral loss of more than a single tooth. It can be easily adjusted to allow for the eruption of teeth. As artificial teeth are included in the denture, it restores normal masticatory function. However, from its disadvantages, that it is easily broken from a child. If the appliance is removed from the mouth even for few days, changes in the denture base will occur and drifting of teeth may make it impossible for the child to replace the appliance unless extensive adjustment has to be done by the dentist. There is a possibility of the development of new carious lesions unless proper cleaning of the teeth and denture is performed. From the retention point of view, stainless steel wire clasps are contoured for the canines if they are present, and stainless steel wire rests for molars. If the permanent incisors are in an active state of eruption, it is advisable to remove the clasps after the child has become accustomed to wear the appliance to allow the distal drifting and lateral movement of the canines and alignment of the permanent incisors. If the loss of one or both of the second primary molar occurs a short time before the eruption of the first permanent molars, the acrylic partial denture may be preferable than the distal shoe-type maintainer. The distal border of the acrylic should approximate the mesial surface of the unerupted first permanent molars. Scraping the model in this area to produce an accentuated post-dam may influence the first permanent molar favorably in its eruption. 2. Passive lingual arch. It is sometimes the space maintainer of choice following the multiple loss of teeth in the maxillary or mandibular arch. Although it does not satisfy the requirements of restoring function, the appliance has many advantages. It eliminates the problem of patient cooperation. There is no breakage problem, no concern whether the child is actually wearing the appliance, and the problem of increase in dental caries activity is considerably lessened. Passive lingual arch. Orthodontic bands are adapted on the first permanent molars or the most posterior teeth in the arch. An alginate impression of the entire arch is taken, the bands are removed from the teeth placed in the impression, and a stone model is prepared. 0.8 mm stainless steel wire should be contoured to the arch, extending forward and making contact with the cingulum portion of the incisors at the gingival margin, order that the arch wire will not interfere with them. The arch wire should be extended posteriorly along the middle third of the lingual surfaces of the molar bands and soldered in this position in an inactive state. After polishing, it can be cemented in the mouth, after polishing the abutment teeth and drying them. The appliance should be entirely passive to prevent undesirable movement of the teeth. 3. Active lingual arch. In case of multiple loss of teeth and loss of space in older children where the first permanent molars and mandibular and maxillary incisors are fully erupted. This active lingual arch, with U-loops, will be constructed and the bands will be cemented to the first permanent molars. Before insertion of the arch, the U-loops will be activated, thus, it will act on the molars to distalize them. 4. Transpalatal bar. Bands will be adapted to the maxillary first permanent molar and a bar adapted to the palate will be soldered to the bands, thus preventing the maxillary molars from mesial movement as it rotates around its palatal root. Transpalatal bar. 5. Active transpalatal bar, when there is mesial movement of the maxillary first permanent molar with rotation, a U-loop will be constructed to distalize and regain the original position of the maxillary molars. 6. Full dentures for children. Some children may have all of their teeth removed because of the widespread of oral infection or because the teeth are extensively decayed and/or in cases of complete anodontia. Young children can put complete dentures successfully before the eruption of the permanent teeth. G-space maintenance for the first permanent molar area. 1. Loss of first permanent molar after eruption of the second permanent molars. When the first permanent molar is lost after the eruption of the second permanent molar, consultation with the orthodontist is desirable, and the following points should be considered. Is the child in need of corrective treatment other than in the first permanent molar area? Should the space be maintained for fixed bridge work? Or should the second molar be moved forward bodily into the area formerly occupied by the first molar? The latter choice is almost satisfactory even though there will be a difference in the number of molars in the opposing arch. A third molar can often be removed to compensate for the difference. If it is decided that the space should be maintained by band or stainless steel crown and loop, space maintainer can be constructed. A modified fixed bridge can also be used, although gingival recession will continue and margin of restoration may be exposed. It can be replaced with another bridge after completion of growth and ceasing of all active and passive eruption. 2. Loss of the first permanent molar before the eruption of the second permanent molar. If no treatment is performed, the second permanent molar will drift mesiali prior to eruption. Repositioning of this tooth by the orthodontist is possible after its eruption. However, the child must then be considered for prolonged space maintenance until the time when a fixed bridge can be constructed. If the first permanent molars are removed several years prior to the eruption of the second permanent molar, there is an excellent chance that second molars will erupt in an acceptable position. However, the axial inclination of the second molars, particularly in the lower arch, may be slightly greater than normal. The decision to allow the second molar to drift mesiali or to be guided forward in an upright position may be influenced by the presence of a third molar of normal size. If there is a question regarding the favorable development of a third molar on the affected side, then the decision to reposition the drifted second molar and hold it for fixed bridge work is the treatment of choice. If it is decided that the space should be maintained, band and loop or stainless steel crown and loop with distal shoe extension is the space maintainer of choice. The above-mentioned classification of space maintainers can be summarized in the following: classification according to function: restoration, functional, non-functional. Classification according to activity: active, passive. Classification according to retention means: fixed, semi-fixed, removable. Thank you.